should be very loud. So in
Okay.
1 minute from now, we'll start, inshallah.
Okay, no problem.
Okay, thank you very much. Okay.
Our colleague from Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. I would like to welcome our colleague from East Jeddah Hospital in the Western region. As we promised at the start of this year, we'll do a series of lectures from Western region every month. Our colleague from East Jeddah, Dr. Yahya Benafe, and his lecturer, Dr. Sebastian, will present today about drowning management in pediatric ICU. I will leave Dr. Yahya Benafe to introduce Dr. Sebastian and to listen for the lecture. Please go ahead.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. بسم الله الحمد لله والصلاة والسلام على رسول الله. First of all, in the behalf of PICU team in East Jeddah Hospital, I would like to thank Dr. Adib for her grateful efforts and support for this scientific meeting and continuity. And I would like also to thank the audience. Our speaker today is Dr. Sebastian. He is PICU consultant in East Jeddah Hospital. He joined us 1 year ago. And since that time, we are happy to meet him. He is Dr. Sebastian. He was the PICU, the head of the PICU in military hospital in Buenos Aires. And he is a cardiac ICU consultant in National Hospital Carajan in Argentina. Welcome, Dr. Sebastian. Our topics will be today on drowning.
Well, thank you for everyone. I'm Dr. Sebastian. Thank you for the invitation and this introduction. Marhaban bil jamia. We're going to start. Okay, let's press the button. If you don't hear me well or not clear, the World Organization, one of the leading causes of death globally for children and young people from the age from 1 to 24 years are drowning cases. And with an estimated here, we have the number, 236,000 people are drowned per year. And is the leading cause of death worldwide among boys between 5 to 14 years of age. We have key risk factors for drowning that, for example, the 14 years, alcohol or drug abuse, low income, poor education, rural residency, aquatic exposure, risky behavior, and lack of supervision. And for people with epilepsy, the risk of drowning is 15 to 19 times as high as the risk for those who do not have epilepsy. And this is the new definition adopted by the organization. And they say that drowning is the process of experiencing respiratory impairment from submersion or immersion in a liquid. But any submersion or immersion incident without the evidence of respiratory impairment should be considered as a water rescue and not a drowning, okay? But the person airways, which is below the surface of the liquid, like here, is a case of submersion. And if the water splashes over the face, it's an immersion. This picture is a little creepy, I know, but summarize well what happened, for example, at home. And this is really common in our pediatric children. And the toilets, the big buckets, or even when they're taking a bath with or without seats or rings that are not safety devices. The terms such as that this is a term really common. I've had drowning, active or passive, we have to avoid. And the non-fatal. But in the case the person dies at any time of drowning, the fast drowning. I think this is simple or common or obvious, but I think it's going to explain why the management we're going to take after. And when a drowning person can no longer keep the airway clear, the water is entering in the mouth, and then they try to spit out or swallow. But the next conscious response is to hold one's breath. But it takes no more than 1 minute, no, just 1-2 minutes. And when the inspiratory drive is too high to resist, some amount of water is aspirated into the airways, and the coughing occurs as a reflex response. Sometimes we see the laryngospasm, but in such cases, terminated by the onset of the brain hypoxia. The laryngospasm as direct reflex, trying just to stop the entering of the water in the airways, are developing asphyxia. And also the person that is not rescued, and we have aspiration of water continues, and the hypoxemia leads to loss of consciousness and also apnea. And the sequence of the cardiac rhythm, is deteriorating with tachycardia, bradycardia, and finally asystole. This is an interesting article in the Physiology Journal in 2016 that talks about the example for immersion in cold water. And in this, when the face cold water just, getting in contact with the cold water, they have the diving response, as I said before. And then they start a parasympathetic stimulation that leads to bradycardia. On the other hand, the cutaneous in the skin, the cutaneous called receptors, the sympathetic, and is becoming with tachycardia. So this is an autonomic conflict that if it's hypothesized that together this conflict inputs to a heart can lead to arrhythmia. On more if we have myocardial hypertrophy or channelopathies or atherosclerosis. So this is why the cardiovascular system and the arrhythmia in a previously health so common, and we're dealing in a short period with a cardiac arrest. This is one of the review articles that I saw that is really nice. It's in the New England Journal of Medicine. It's about drowning from David Spitzelman and collaborations with the countries of Brazil, United Kingdom, Netherlands, and USA. And it talks about all the management about for example, divided in three, the pre-hospital care, and also mechanism of resuscitation immediately. The beds, we're not hospital care because systems are public, but I'm going to some things and ER and this.
I think there is a problem in the sound. Anyone has any problem with sound or except me?
Excuse me, doctor, there's no sound.
The voice is not clear, Yahya.
Yeah, I'm trying to call him from where I'm trying to call Sebastian. Hello? Hello? Yeah, Dr. Sebastian. Hello, Dr. Sebastian.
Sebastian, we cannot hear you. Sebastian, if you are listening for me, we cannot hear you. Can you double check your mic?
Dr. Sebastian, I'm trying to call you by phone. Dr. Sebastian. Yes, okay, you can start from here.
Yeah,
Oh,
please
well.
silence.
Yes.
Yes, okay.
Go ahead, man.
Go ahead.
Sorry about the inconvenience. I didn't.
Nice.
But yes, just because also all the time they're calling me. That's why I put it in silence mode.
No problem.
And I said a hand, but well, okay, this is not the time for the questions. So that's why. Well, sorry to everyone. Yes.
Okay.
Okay. Well, we're going to start. Well, this is the physiology journal that talks about what happened with the cold water immersion phase in a victim of the drowning, and develops the diving response, as we said in the pathophysiology, and develops a parasympathetic stimulation and bradycardia. And for the other hand, we have the cutaneous cold receptors that develops a sympathetic stimulation with tachycardia. So that's why they make an autonomic conflict, and that's why the developing of arrhythmias are so common. And this is the explanation why we're dealing with arrhythmias and myocardial dysfunction after not only CPR, but because the arrest is too soon and in previously healthy children. Okay, we're going to analyze with this article from the New England Journal of Medicine. It's from David Spilsman in collaboration with Brazil, United Kingdom, Netherlands, and United States. And it's really nice to read and talk about, well, all the management in drowning patients, and divided in pre-hospital care that we're not going to talk now, and ER, some kind of topics, and in PICU, obviously the main lecture of today. Also, this graphic is like a clinical management that we have to see, and this is really helpful, but well, seems to be like overwhelmed and divided in two. And we are talking about the grades. The grade 1 in the patients that arrive to the hospital is the patient that is conscious, that they have a normal auscultation. And the grade 2 is we have presence of crepitations and need oxygen, but is completely well. The rate of survival is really high, 100%, and maybe no need to be admitted in PICU, and could it be in ER, 24 hours of observation, and then could discharge. Well, obviously, in each case, it has to be a different management. But the grade 3 to 6, well, this could be a PICU admission, and the grade 3 has pulmonary edema without shock. The grade 4 is pulmonary edema with shock. The grade 5 is when we have apnea with pulse, but in the grade 6, as we say here, just we have to start CPR because we don't have any pulse. Obviously, the survival rate decreased a lot to 7 to 12%. What happened in ER? Well, ER, we have to work with them and collect this information about the patient. I think these 3 items summarize the most important things to get in mind when we arrive to ER. And also here, that remove wet clothing is really important because the cold and dead is not the same as appear dead because they are cold, okay? It's not the same. We have to just to prepare to rewarm the patient, and also the CPR with high quality is really important. We have to remove wet clothes, actively dry, and actively warm, supply warm blankets, or use infrared lamps, or use warm IV fluids to 39%, or gastric lavage with normosaline with 42 degrees, but this is really important. What about the time that I was explaining in silence by myself? Let's talk about this. This study from the British Medical Journal in 2015, answering the question if the resuscitation after 30 minutes in drowning children with cardiac arrest and hypothermia leads to a good outcome. And this is a retrospective study made in Netherlands for the period of 19 years, 19. The poor outcome was defined as death, or if they have a score of PCPC more than 4. PCPC is Pediatric Cerebral Performance Category. What is more than 4? Severe neurological disability or vegetative state. And this is measuring at the time of the primary outcome and then 1 year after. And after these 30 minutes, we have the decision 3 here. After 30 minutes, we have to see if we have a return of spontaneous circulation, ROSC. If we don't have anything, we stop the resuscitation. And if we have a successful response, the patient goes to PICU. These are only exceptional circumstances that maybe the presence of the rapid hypothermia before asphyxia could have protective effect on cerebral damage. So they have specific time, or for example, fibrillation at the time, ventricular fibrillation at the time of the starting CPR and after 30 minutes, and we could continue with the reanimation. Only in that cases, if not, they suggest stop the CPR. And what about if we have just more than 10 minutes? We have this article from the eCPR. This article is from World Journal of Pediatric and Congenital Heart Surgery in 2019. It's a single center retrospective study from Columbia University in New York, and it's talking about the eCPR, the extracorporeal cardiopulmonary resuscitation in 71 patients for a period of 7 years. The cannulation was divided in central by sternotomy and femoral or in the neck. And they said that they revealed that the children with hospital CPR for more than 10 minutes, the eCPR has been associated with improvement in the survival to hospital discharge and survival with favorable neurologic outcomes. So it has to be, if you have the possibility to do eCPR, it's a good tool just to get in mind. What happened in PICU? Well, I'm going to talk about the management in a drowning patient in the intensive care unit. We have insufficient published data to guide optimal specific management, but we should follow general guidance post-cardiac arrest syndrome. We have to think in a global hypoxic ischemic insult with reperfusion. And the key components of brain injury, myocardial dysfunction, as I said, systemic ischemia and reperfusion And this is the defining management priorities. For the neurology, we have this article from Neurocritical Care they're made by the team of the Children's Hospital of Philadelphia, Pittsburgh, and also Skåne University in Sweden, and talks about the brain resuscitation in the drowning patients. This is like a consensus and provide recommendations for management and investigation in this kind of patients. We have to know that the hypoxemia and the ischemia cause neural damage, which can produce cerebral edema and elevation in the intracranial pressure, the ICP. And this is observed approximately in 24 hours after the injury, only 24 hours. That's why I talked before about the pathophysiology. What about, and the bad news is that the approximately 20% of the non-fatal drowning victims has a neurological damage and limiting the functional recovery. And this is all despite the successful cardiopulmonary resuscitation. So, well, what happened, just to get in mind, cerebral hypoperfusion, we're going to deal with this. So the hypoxic ischemic injury and then reperfusion injury is going to be present. The loss of cerebrovascular autoregulation is lost, and we have a presence of cerebral edema. One thing to get the neuroprotection is head up to 30 degrees, avoid hypoxia, saturation has to be normal in a range of 94 to 98, and also avoid hypercapnia. Maintain adequate MAP, the mean arterial pressure, and avoid hypotension. This is really important, we're going to talk later. We need sometimes to decrease the oxygen consumption, sedation, and paralysis. But if it's possible to avoid the paralysis, the muscle paralysis, because it can obscure the seizures activity. The anti-epileptic medication as a prophylaxis is not indicated, and we can treat the seizures as usual, as a PALS guidelines. We can use benzodiazepines, Keppra, Phenytoin, and take really good caution with the thiopental. Yeah. One of the most important thing that I want just to make clear is we have to avoid hyperthermia, and we have to treat aggressively if occurs. The fever is incredibly common post-ROSC. So the episode of fever more than 38 degrees are strongly associated with poor neurological outcome. Well, what happened with the therapeutic hypothermia? This is controversial, and then at the end of this lecture, I want to hear all the audience about what are they using or not, what they're thinking or not. I have my own experience, and also I'm going to talk about the THAPCA trials. The THAPCA trials I have here, it's not so big, I think. Yeah, sorry about, but well, this is the system. Is the therapeutic hypothermia after the cardiac arrest in pediatric patient, okay, in children. The therapeutic hypothermia has been successfly used in adults after cardiac arrest to improve survival and outcome, but has been studied in newborns because of the perinatal asphyxia, but it has not been studied in children after a cardiac arrest. And they were enrolled around 900 children in this study over 6 years in 38 clinical centers throughout the United States and Canada, starting from 2009 and ending in February 2015. This article is publishing in New England Journal of Medicine at the time of the 2015, and has another differentiate about the in-hospital arrest or out-of-hospital arrest in 2017. But the conclusions are the same. And what they say, well, they compare two temperature interventions within 6 hours after ROSC, they get children that has to be more than 48 hours of age and less than 18 years, and they randomly assign in a ratio 1:1, just go to therapeutic hypothermia. They target temperatures 33 degrees, put a blanket, you know, a blanket covering the patient and with a machine, a cooler blanket, or the therapeutic normothermia. That is the target temperatures 36.8. And the primary outcome was to be the survival at 12 months. And with the score that has to, from neurodevelopmental, it's okay, that is the, has to be more than 70, okay? So the rate of the primary efficacy outcome did not differ significantly between the hypothermic group and the normothermic group. This is with a relative risk of 0.92 and a 95% of confidence interval. So the recommendation about this trial is the same, just to do with the hypothermia that without. The hypothermia is with 48 hours in that at that temperature, 33 degrees, and then around 16 hours start to get to rewarm to 36.8. The most important thing I'm going to say again is just the importance of avoid hyperthermia, that this is what you get the best outcome in a neurological way. The other thing to get in your mind, the PICU, is try to get neuro monitoring. Okay, the standard neurologic examination, I think, is the most pragmatic tool, and it's not as clear which patient have altered mental status or coma and have a poor outcome. But the large and unreactive pupils are the hallmark of the IgE. While the pupillar response may return after the arrest, the absence of the pupillar response at 24 hours is associated with poor neurologic outcome. Okay, so, but we don't know if the patient is awake. Seems to be that the patient are awake at the time of admission in EICU, the patients do well. But if the patient is not responding in the first 24 hours of resuscitation, well, it's not uniform, the response of the outcome. Sometimes are poor, sometimes are good, with a good outcome. The thing that they have in the literature is the Glasgow Coma Scale score less than 5 and ICU admission after drowning is associated with poor outcome. What about the EEG? Well, this is a non-invasive monitoring technique. This is really helpful. This is examples. For example, this is a normal EEG. This is when we have a burst suppression. The burst suppression is when you have a high electrical activity, and then we have the isoelectric function. Well, okay, this is the burst suppression. This is when the patient has seizures, and this is when the patient has, a comatose patient. Obviously, B, C, and D has not a good neurological outcome, and that is the thing that we can take in the bedside of the patient. Neuroimaging also, we need that the CT scan. This is not a CT, sorry, this is an MRI, but I'm talking about the CT. It's useful also to detect the head and neck trauma, and also we can see if there is presence at the time of admission, the cerebral edema, which is associated with poor outcome. So the first time the CT is a recommendation, and then the MRI at these cases, that is the DWI, that is diffusion weight imaging, can detect injury within minutes after ischemia and improves the ability to predict the poor outcome. In these cases, we have two patients here, A, B, and C. Is the 4-year-old cold water drowned victim who was present in a temperature at the time of admission of 23 degrees, and the MRI 4 days after was completely normal and also a normal neurological examination. But this case, unfortunately, 13-month-old, that is a bath tube drowning victim, was present by a core temperature of 33 degrees, and the MRI 4 days after the accident showed this increase in the signal of and restrictive diffusion, yes, in the basal ganglia. That is really common just to see. Where's the arrows? And in the globus pallidus, okay? The MR spectroscopy evaluates the metabolic profile of the brain, but it's not good at the first days. Could be helpful in the 3 to 4 days after the drowning and the cardiac arrest. And we have also the somatosensory evoked potential, SSEV, and the DS, and the absence in the first 24 hours are also highly predictive to poor outcome. What about the Icp monitoring? We know that intracranial hypertension is common after drowning, as I said, because of the cerebral edema. It's likely a cytotoxic cerebral edema due to energy failure and transit of water into the intracellular compartment. And also this can contribute to intracranial hypertension and decrease the CVF. But currently the Icp monitoring is not routinely used following drowning because we don't have any randomized trial that are available and measuring that, did not correlate the cerebral edema and the Icp monitoring in the impact of the drowning outcome, okay? I'm talking about specifically in this kind of patients. NIRS is another non-invasive technique that we can help us if you have it, only for splenic and also in the forehead, just to get about the metabolic consumption. And the biomarkers, well, there's a few data. There's kind of NSE are the most studied, but it's not anything that we're doing just as a routine, and we need more. The data is scarce and conflicting, and we need more investigation about that thing. Maybe troponin, plasma glucose, pH, lactate are more helpful at the time of admission, and we can see a better prognostication of the patient, okay? Well, are you live? Okay, we're going to talk, okay, good, nice to hear you. What about the respiratory things? Well, this is another issue because the water is entering in the airway and also washes all the architectural structures of the lungs. So if do not doing an intubation during the CPR, we have to secure the airway. Sometimes the admission in PICU is not correlate mandatory to just to get in mechanical ventilation. It's the majority of the cases, but you can use positive pressure, you can use high flow oxygen, or any devices. But it's the most important thing is to secure the airway with a cuff ET2. The use of cardiostable induction to avoid hypotension. We can discuss the ketamine using about the ICP and the ketamine, but I know that the next lectures are talking about the TBI, the trauma, brain injury. Well, this is a nice topic just to discuss, but well, with this, I try to say we need something to avoid the severe hypertension. We have to keep cuff pressure less than 20, and obviously we have to confirm the position of the tube with the chest X-ray. We have to avoid nasal intubation because we have a coagulopathy likely. Obviously, as you know, we have a high risk of ARDS and an acute lung injury, and also the bronchospasm is often to see, and we have to treat similar to acute asthma. Most of the cases are rapidly improved with inhaled beta adrenergic agonist. What about the management for the ventilator? We have to maintain an adequate ventilation with an AIM normocapnia. This is not a patient just to get the permissive hypercapnia, because we have to deal with the brain security for say, okay, just to get in the mind that our primary is just to do not have a secondary injury in the brain, okay? So that's why the thing that is maybe is not typical from our management of the ARDS, and also the steroids are not, we don't have any good evidence to support the routine use of steroids. In some cases, you can use it. We have to maintain an adequate oxygenation with a saturation between 94 to 98. We have to see that we have to avoid the hypoxia, and the hyperoxia is increased the mortality, especially in adults. The setting of the ventilator has to, we have to avoid any associated lung injury, and the tidal volume has to be 6 milliliters per kg, the plateau pressure less than 30. We have to titrate optimal PEEP, and the FiO2 less than 60. These X-rays correspond to our last patient that we have, a drowning victim of 12 years old, was a French boy that was swimming with his twin brother in a private beach in Jeddah, in the north of the city, and was history of epilepsy, and suddenly get drowned. The brother comes to start resuscitation, go to another hospital, the King Abdullah Medical Complex, and then come to us. Well, this is at the time of admission, you can see clearly, affecting how is the ARDS, okay, looks like. And also, but fortunately in this case, we have and 48 hours, this is the next X-ray that improves, and we can extubate the patient without any complication and with a good neurologic outcome. But sometimes it's not so easy. And like in this paper, there is a letter to editor for PICU in Italy that talks about the use of surfactant, because the water washes the surfactant from inside the lung, and sometimes could it be a problem. We used last year in one patient, he was in high frequency and with a very good outcome and a very good, excellent response. So you have to get in mind, maybe not routinely, but you have to get in mind, okay? There's no trials to have performed that you have to use surfactant. Like in this case, they use 50 milligrams per kg through the bronchoscopy, okay, in both lungs. And well, the response was really nice. So recommended in these two patients from 11 and 12 years old. What about cardiology? This is the three, neurology, respiratory, and cardiology are the main, the main management and the most important thing. The hemodynamics are mostly with low cardiac output and with high resistance. So we have a myocardial dysfunction with the global stent of the heart with reduced the contractility. This is because of the reperfusion injury and the tissue edema. This can occur in the first 30 minutes post-ROSC, and we have and did in the first 8 hours. So then after, the patient can recover near to normal function. So this is post-arrest, and this is in the first 48 to 72 hours. And we have to avoid the hypotension, as I said before, because increase the mortality and the morbidity. And we have also, well, as usual, we have to just do, monitoring as usual with arterial line, CVP, urinary catheter, send UE, CRP, urine output, lactate, mixed venous saturation, and good ECG, and obviously an echo with our friend, Dr. Abdullah. If we need to preload the patient, has to be very careful, because we have a stent myocardial. We're dealing with the myocardial dysfunction, and this is really common due to us in the cardiac units, but not in the general. Nobody's going to just to make 5 milliliters per kg as a bolus, but yes, you can, and you can also check the effect in the clinical way, and also the contractility and afterload. I'm talking about the stroke volume, obviously. If hypotensive, we need to start with a low dose of adrenaline of 0.5 to 0.1 micrograms per kg per minute. If the blood pressure allows you, you can start also with milrinone or dobutamine, and we have to avoid the pure vasoconstrictors because increasing more the resistance that are high. The oxygen, just to improve the delivery of oxygen, we need to consider the PAC-RVC, and I'm going to talk about that later. And the arrhythmia we see as before, that is really common, that the patient also develops another arrhythmia. And in that case, I mean, for one hand, it's because of the myocardial insult, and for the other, because we're dealing with an inotropic support. And well, in that case, we need to treat as the pulse guidelines. What about GI? Well, I'm not going just to get in deep in this. We need a gut protection because we have systemic hypoperfusion and also the use of vasoactive drugs in the majority of the cases. So we have diffuse ischemic insult to bowel. NIRS could help with us also. Okay, we have a splenic patch. In this case, we have to use a PPI and consider enteral feeding after the 24 hours with isotonic IV fluids maintenance around 80% and avoid hypoglycemia. What about metabolic? Okay, yes, we're talking about the hypoglycemia. Your target is the normal glycemia. The worst outcomes are with hypo or hyperglycemia, also with the brain insult. So we have to consider insulin if we have a blood glucose for more than 10 or 12 millimole per liter. 10 obviously is around 100, 180 milligrams per deciliter. What about electrolyte disturbances? We have to just to make sure that that's corrected. Well, all the in normal values. And about the adrenal insufficiency, we have no evidence of giving hydrocortisone unless we are dealing with a refractory hypertension. No specific evidence of renal replacement therapy. We are dealing with the IKI, acute kidney injury is really common because the hyperperfusion and also the use of the vasoactive drug use. And we have to keep the management and as all critically ill patients as the day by day. What about using antibiotics? Well, prophylactic antibiotics are not indicated, but we can start in the cases that we suspected and covering Pseudomonas, Eromonas, Proteus, and also if the water is not clear and or is dirty, sometimes in the swimming pool, we have to a good cover, a broad spectrum antimicrobial, and send cultures, obviously. Coagulation derangement and platelets aggregation could develop a microvascular thrombosis and injury in the end organ. So no, there's no recommendation, as we said in the lecture before, the last month. Also, we're going just to go in the same direction. If the hemoglobin and the patient is stable, hemoglobin more than 7, it's okay. But and the hemoglobin, if the patient is unstable or with ARDS, and well, okay, when it's unstable, more than 10, maybe is the target. The platelets more than 50, and the coagulation profile also with the PT less than 18 and APTT less than 50. Okay. Let's talk about the poor prognosis. All the data are talking about the duration of the submersion more than 5 minutes. The time to effective BLS in the scenario that the drowning are happening more than 10 minutes is poor prognosis. The CPR, more than 25 minutes to 30 minutes, as we said, the age of more than 14 years old, as we said, the Glasgow scale at the time of admission less than 5, or CPR in ER continuously, or well, a persistent apnea and no responding. Also at the time of admission, a pH and the arterial blood gas less than 7.1. Well, it's are signs of bad prognosis. But we have a good thing just to get in the mind, and this we have a prevention. And for example, because this is a tragedy, the patient is completely normal before being a victim. And for example, the secure foresight of the swimming pool and putting a gate in the patients that is, or I mean, in kids that are less than 4 years, has a prevention in an 80%. Also have an adult supervision, or swimming with a partner are not alone, or using devices, or warning to the parents in the when we're talking with them as pediatrics, general pediatrics, that they have to be warned about the shallow areas like toilets or buckets of water. This is the articles that I searched from Saudi Arabia, and this is the experience in Asir Central Hospital from Dr. Suleiman Al-Fifi. And this is, well, really interesting. The conclusions are the same as in the international literature. And they're talking about, well, the type of the population. I mean, how many are drowning because of submersion versus immersion. And what about the, well, cardiac arrest was reported as 42% of the victims, okay, are the same, and the data the same in Dr. Mohammed Jan in King Abdulaziz University in Jeddah, and also this article in the Annals of Saudi Medicine, that is the experience in King Khalid University Hospital in Riyadh from Dr. Saleh Al-Mufada. And this takes a retrospective study of 10 years. And I think that there's something that is, I'm talking about the poor prognosis, because only one of the 21 cases that they have private swimming pools have had the features compatible with swimming pool safety regulations. Only one of 21. So this is really important just to get in mind. And the other thing is that the absence of vital signs, the Glasgow scale less than 4, at the pH at the time of arrival less than 7, and the blood sugar more than 10, obviously are predictive of bad outcome. You know, this is a statistical significance, and this is the same as we said before with the poor prognosis. So congratulations for this. Maybe are more. I just searched these 3, but it's really, they are really amazing. Well, thank you to everyone. But if you get me just 1 minute more, I want to make a special thank you to all the people in PICU team in Jeddah who support me since the first day. Okay, we have this picture, Dr. Heya and Dr. Fadma, the actual head of department, and also the specialists, the residents, the nurses, RT. This is Amir, a resident, another one. And obviously my family, my wife, Analia, my 3 beautiful kids, Facundo, Nicolas, and Isabella, my dog, Deepa. Then they support me to do this adventure. And also my friends whom I can discover and enjoy this amazing and beautiful city that is Jeddah. And also, I like to invite you to the pre-conference workshop, the first day of October, in the pediatric mechanical ventilation course that I'm going to be there. So, well, thank you very much, Shukran.
Thank you, Dr. Sebastian, for this lecture, and thank you for the audience. Now we have a time for questions. Okay, and does anyone, Dr. Adib, is anyone having any comment or any questions regarding this topics?
Yeah, I see many people raising your hands, so I'm going to start from the first one, which is Junaline State. Vergara, please unmute yourself. I think she's not with us anymore. Junaline State Vergara, unmute yourself, please. So we'll go to May Erlang Henking. May Erlang Henking. Looks like they forget to add that. Dr. Mohammed Musa. Mohammed Musa, unmute yourself.
Yes. Thank you so much for such a great presentation. I really appreciate it. I have one question regarding muscular relaxant. Really, sometimes if we are using like the patient we are managing like status epilepticus, patient is not responding as phenobarbital, phenytoin, and many drugs really. So what is the role of muscular relaxant in controlling of the seizures? Is there any role?
Yeah, Dr. Speciant.
Yes, I can hear the when they have we have to avoid with antiepileptic medication, but I can't understand what is the question.
Can you hear me, please? Can you hear me now?
Yeah, we hear you.
Am I audible?
Now I can hear you better.
Yes, my question is regarding muscular relaxants. Sometimes,
yeah. Okay.
Yes.
Sorry,
sometimes we are giving all anti-epileptic and patient is seizing still. So, is there any role of muscular relaxant in drowning patient to control the?
Well, yes. Definitely, you have to use it because sometimes when you're getting the patient through therapeutic hypothermia, you need to decrease the consumption of oxygen. And also, if you're dealing with a drowning case and you have a CPR, the ROSC, you're acting like a ROSC. So paralysis with neuromuscular blocks, Beckronian, for example, and the use of sedation is mandatory. But the thing is that they're not going to, they have that, as I said, they obscure the activity. So you have to just to check with the EEG that the patient is not developing seizures, because the seizures are really harmful, and the outcome, the neurological outcome, is really bad in that case. So like hyperthermia, avoid seizures, has to be ruled out. So in the case that you need it, because you have to keep the patient fully sedated with sedation, high sedation, and neuromuscular block, you can use it, but you have to check that the patient is not seizuring. In the case that the patient is seizuring, you have to just, as any status epilepticus, you have to just to get the guidelines just to avoid them.
Thank you
so much. Sorry, there is one more very small question. What about the role of prophylactic paracetamol? Can we start from the already patient are hypothermic? If there is seizure activity,
yes,
ultimately patient will develop hyperthermia within minutes. So is
yes,
there a role of paracetamol? We will start like Q6 hourly or like Q4 hour, Q6 hourly. Is there a role of prophylactic paracetamol for these patients?
Yes, obviously it's really helpful. We don't have any specific deal with the, with the hepatic, after ROSC, there could be a touch, in the LFT, but it's not a contraindication to use paracetamol, for example, Q6, okay? And if you have the possibility to use a cooler, like a blanket, this is the most, you know, the most thing just to achieve, because you need to avoid the hyperthermia. You know, at the time of the using hypothermia versus normothermia, there was a lot of data about why the other in years before they prefer the hypothermia, and because they one of the hypotheses is that they didn't use to avoid hyperthermia, so they just compare nothing, no control, and hypothermia, and obviously win hypothermia. Now this trial gets the control hypothermia and control normothermia, and that is not any differences in the results. But yes, you can use it because, as I said, most important thing is just to avoid hyperthermia, and it's really common. It's a really common thing. If you can do the management with drugs and with physical, with wet clothes and cooler, yes, obviously, are welcome.
Thank you so much. One more question regarding prognosis.
Musa, please, Dr. Musa, please, can we just, because we have a lot of speakers and we have limited time, so can we move
okay, no problem, no problem. It's okay for me. Thank you so much. Thank you so much for your great
question in the chat. We can answer it later.
No problem. I will write in the chat. Thank you so much. Thank you so much.
Please, can we move to Samira Bakar Arba? So the second, Samira is not speaking. The Flor Delisa Sarza. Flor Delisa Sarza. Next to speak question from Dr. Ashehri, our senior pediatric intensivist from Riyadh. Dr. Saleh, please go ahead.
Assalamu alaikum. Thank you very much for the speaker for the very good comprehensive review about this topic, and he brought a lot of clinical attention to this entity of injuries coming to the ICU. I have a comment regarding the surfactant use in patients who developed ERDS, and I use it in one patient, and it helped getting patient out of the high frequency support, and luckily this patient recovered. Surprisingly, was recovered also with very good neurological outcome. And the second comment which I would like to say about the patients who passed the ROSC state from the ER, and he need to come to the ICU for the neuro ICU care initially for the first 96 hours, 72 hours. I find the Glasgow scale estimation in the ER is misleading. That's why we decide to give the patient benefit of doubt to go for the very good TBI, protocol, adjusted TBI protocol, as the speaker mentioned. And yes, we don't have that very good outcome, but at least few cases, they have come out of the ventilation with some favorable neurological outcome. My question to the speaker, what is the literature review finding in terms of the sure criteria to palliate the patient after the neuroprotection? What do you think? I know the literature is mentioning that the outcome in the long term is not good, but are we, in terms of palliation therapy, are we doing it early, or it is just left for the time to declare the patient? Thank you very much.
A very interesting question about the use of surfactant. Yes, when we used it last year in this specific patient was in high frequency also, and the outcome was really good. yes, but there was nothing that we are doing in all the patients, obviously. And what about the neurological outcome? It's a really good question. You know, all the data are taking action about the first 24 to 48 hours, and then after, sometimes you have to, if you choose to make the patient with hypothermia, you have to rewarm first. You rewarm the patient, and then you have to get it in normal thermia. And if you are not choosing normal thermia, hypothermia, sorry, and you give it in normal thermia, you have to just to act about the 48 to 72 hours, and then reassess if you are dealing with the brain death or not. Sometimes, yes, it's really common to see that in ER, they're just like dealing with the CPR, but they don't have the questions that we have in PICU, and we have to treat them. So what happened? This is only the pupils, only the CT, the EEG. We have a lot of things, but nothing is just get really and 100% accurate outcome that what happened. So that's why they need just to take time and the first 48 to 72 hours and reassess if you are with a patient that is with brain death, and take the test as usual as any patient, and then we'll follow the case. It's clear.
There is no more questions in the group. We'll just give another 2 minutes. But I have a question for you, Dr. Specian, for me, Adib.
Okay, Dr. Adib, nice to meet you. Yeah.
Nice to meet you too. You are some kind work in our country now for 1 or 2 years, and you see you are in one of the biggest hospitals here in Jeddah who receive a variety of population with near drowning and drowning in the kids. And you see our percentage in the summertime getting higher. What happened back in your country? Do you have a near or drowning or swimming protocols for homes, for swimming pool at homes, from area of safety criteria? Because I think we as intensivists or as hospital pediatrician, we have a major role to educate our population about using swimming pools precautions.
Well, unfortunately, we don't have it. It's really common as here. We're dealing in every summer. I know obviously the summer season, and Buenos Aires is in Argentina, in South America, obviously. It's beside the coast, but you can swimming in that only in the beaches in the south of Buenos Aires, not in the capital city. But we're dealing with a lot of swimming pools, and there's no the same thing that I saw in the articles that I saw here from the kingdom. We don't have specific, but we have, and also that's why the World Health Organization in the page has a prevent day, and they trying just to teach for the adult supervision, because it's one of the most important things, the lack of supervision, and sometimes could be a minute. The last case that we have that I saw, that I said in the lecture about it was here in a private beach, was just around minutes, and you see the X-ray, and well, this is sometimes it's 1 minute and you have a tragedy. So
if you don't mind, we're gonna receive question from Dr. Hani Timsah, our PICU consultant in the King Khalid University Hospital in Riyadh. Go ahead, Dr. Hani. Dr. Hani, go ahead.
Assalamu alaikum. Thank you very much. You can hear me?
Yes, perfectly. Thank you,
Adib. Thank you very much. Currently, I'm in Lebanon, so the sound may be interrupted a little bit. I just want to thank Dr. Sebastian about a wonderful topic review.
Thank you.
And unfortunately, in Riyadh also, we see many, not as many as before, alhamdulillah. I think in the last few years, there has been decrease in the near drowning case. I hope, at least from our hospital observation. But really, it's something that makes a big difference to have the bystander CPR, the one that was mentioned by Dr. Sebastian. And again, I really enjoyed the topic so much, the review. Thank you very much, Dr. Sebastian. One question I want to add, please. From your recent review, is there any still benefit of the therapeutic hypothermia? I know it's a case-by-case intervention, but does the literature support using it, or it's just gonna, it's not gonna have so much meaningful change of the neurological outcome of the patient? This is my only question, and thank you all very much again.
Well, it's one question, but it's not easy to answer because we see it's still controversial, and you know, I think this is the trial that has more centers in all United States and Canada, and it's around 38 centers, and they admitted and enrolled around 900 children. But also the study was doing with the randomization of the patients with normothermia and hypothermia, and around 300 only. So this is not just mandatory to, well, you have to do this. But the thing is, when I was a fellow in PICU, it's just like okay, you have to do the hypothermia. This is the, you know, the legacy. The phrase is you have to do it, and now it's changing. We're talking about 2015, 2017. It's not so old, and this is the thing that we have to collect more data. But the centers and the trial is really serious and have consistency, but obviously it's not mandatory to do. In this case, the trial said is the same to use normothermia, and it has to be controlled, the normothermia, and for 5 days. I didn't say that, it was 120 days, the treatment, or use as the use of hypothermia for the first 48 hours, and then complete the 5 days in a controlled normothermia. So the conclusion of this work, of this trial, is the same prognosis at 1 year, and in the second outcome, the same situation with these scales of neurodevelopmental scores. So no need, it's the same situation to do one or the other.
Dr. Adib, if you allow me, I have a comment.
I just, I'm on call, I receive a consult, sorry for that. I think the Dr. Shadish. Yeah. Please go ahead, Dr. Shadish.
Yeah, thank you very much, Sebastian, for this wonderful review. I just have one question. What will be the type of... Can you hear me?
Yes, perfect.
Yeah. I would just like to, I just have one question. What would be the type of fluid that you give for these patients who come with drowning, and its relationship with the development of neurological injury in the first 24 to 48 hours?
Well, okay. This is a really interesting question. I didn't say about it because sometimes there was thinking before that depends on if you have fresh water or the salt water, the type of drowning are changing the electrolyte disturbances. But all the data say that it's the same, because with they need bigger amounts, I mean large amount of for example, salt water, just to make a differences in the changing in the, in the electrolyte as electrolyte disturbances. You have to keep the same at the management of any PICU patient without any change, and use the isotonic fluids.
Thank you.
No, you're welcome.
I think the next question from, again, Iman Ahmed. Iman Ahmed, please unmute yourself. Your voice is not clear, Dr. Iman.
Unfortunately,
Your voice is not clear, Dr. Iman.
is it clear now?
Yeah.
No.
Oh, is it clear now?
Yeah, go ahead, go ahead.
Yes. Actually, I'm calling from States. Unfortunately, I hard lecture, but it seems wonderful. Just one question.
Your voice again is interrupted, Dr. Iman. I'm sorry to say that.
I'm so sorry. Can you hear me now? Can you hear me now?
Go ahead.
Okay. So my question to Dr. Sebastian, if I mean, if you will find a boy floating on the swimming pool, so and he's unconscious, so do you assume that the mechanism here is involving the laryngeal spasm as a diving reflex, and we expect his lung to be dry and he's suffering from anoxia, rather than if you find him sinking down in the pool, and that time you expect that he's most definitely will be having aspiration?
Yes, definitely. Yes, thank you. Do you hear me well now? Okay, because
yes, I can.
Okay, okay. Yes, because the laryngospasm occurs, but only as a reflex, and also develops asphyxia, and the asphyxia has a brain injury and decrease the level of consciousness. So the laryngospasm release and start to come water into the airway. So this is just for a few minutes. It's not persist for a long time. When we see the babies that we're making swimming, you know, with teachers, have the same reflex, and sometimes when you're getting older, you're just losing that type of reflex. But it's the first mechanism, and it's not occurs in 100% of the cases. This is what we say. So you have to deal that if you are not protecting the diving reflex, and this is laryngospasm, it's just for minute, and then you have to deal with that you are full of water inside your lungs.
Yeah, because in many instances we have cases coming, I mean, they will discovered by families floating on the water. So how can you explain this floating? I mean, I think they have some air in their lungs, that's why they are floating. So how can you explain this?
Yeah, it's because it's a matter of time. Depends on the time of submersion or immersion, and that's why I explain. But it's only a reflex.
Yeah, because usually they say if somebody is submersion and he's died, and then he has some bacterial
infection.
I mean, yeah, not infection. I mean, they are down in the sea for a long time, and then there's bacteria with
about the gases
building up.
Gases
yes, and then they will refloat again. But initially, why they are floating, unless they have some air in their lungs? This is my question: how long this spasm will last?
Yeah. This is because of the structure of the lungs. Yes, could it be? Yes, it's well, I don't know actually what happened in the long periods of drowning. But I have to search it and I have to answer you. But I mean, this is for the first steps at the time of with the patient that could survive, and pre-hospital care and fast CPR for just to get any reaction in the case and better outcome.
Yeah, I've been searching for a long time. I mean, because we have cases who are badly affected. They are badly affected, but they are discovered being floated. So this is, I would like to know what's the mechanism here. Is it just the prolonged asphyxia with the spasm, or?
Okay, I don't know. Actually, I don't know. I'm not an expert on drowning. I'm just an intensivist.
Yeah,
but I have to.
Thank you.
But well, I can if I can help you, it's my pleasure.
Yeah, thank you, Dr. Sebastian, for your wonderful lecture. Thank you very much.
Thank you. Thanks to you.
I think the last question will be from Samira Bakar Arba. Please go ahead, Samira. Samira, unmute yourself, please. Look, Samira is right with us in the line again. So we'll go to Jihan. Jihan Saluk, unmute yourself, please. Jihan.
Hello, assalamu alaikum.
Salam rahmatullah barakatuh.
Please, I want to ask about the arterial blood gases. What the change happened in drowning in these cases? The values.
Well, at the time of admission, it's like any cases that you have in the post-arrest patients, that you're going to find problems in the metabolic acidosis, respiratory acidosis, lactic acid increasing. You have to deal with that, and that's why you have to check all the parameters, and you have to restore to normal capnia, normal hypoxia. Okay, this is really mandatory. But at the beginning, it's like any patient that is under cardiac arrest, and this is the same. That's why the management is quite similar to a patient that is receiving prolonged CPR.
I don't think so. We have any more things. I'm going to leave the mic for Dr. Yahya and Dr. Sebastian to close their lecture for today. And before they close, I would like to invite everybody for 3 things. First thing, tomorrow is our colleague King Fahd Medical City. They'll present a case presentation. And our 19th of September, we have also lecture from Western Region for pulmonary hypertension management in pediatric ICU. And the first week of October, we are welcoming everyone to join our yearly conference for Saudi Critical Care Society. Please go ahead, Dr. Yahya and Dr. Banaf, to conclude your meeting.
Okay, thank you. Thank you very much. Thank you, Dr. Adib. Thank you, Dr. Sebastian. Last thing we have want to say that we want to tell that drowning is a major problem in Jeddah, and the hospital receive a lot of patients with drowning. And there is a nice study done in tertiary hospital in Riyadh. It estimated that around 19% of the mortality rate, all of this, the cause of is 19% the cause of drowning. And also they found that majority of swimming pool, they lack of the initial CPR, the lack of the prevention, and there is no supervision, a lot of. And we need here in Jeddah, unfortunately, we didn't find any study. I hope in the future we have a study with regarding these events. Thank you very much, and thank